Hello everybody, welcome to today's lecture. Today's lecture is on thoracic surgery, and in this lecture we will be covering the basic principles of thoracic surgery. So thoracic surgery is basically surgery that deals with surgery of organs that is inside the thoracic cavity. So in this lecture we will be covering the presentation, that is how these patients with thoracic disorders present to you in the clinic. What are the various investigations that are available with us to investigate these patients. We will also have a look at the basic surgical anatomy of the thorax, and what are the various accesses, that is what are the various methods with which we can get into the thoracic cavity to operate on the organs inside. And we will also briefly have a look at what are all the various surgeries that are possible inside the thorax. And at the end of the lecture there will be a short video on insertion of the chest tube, which is very important for every MBBS doctor. So how do these thoracic disorders present? So there are two types of presentations of a patient with thoracic disorders. One set of patients will present to you in the casualty and OPD with severe symptoms. They will be severely breathless, severe tachycardia, some will be cyanotic, some will be having altered sensorium, and when you do an X-ray on these patients, you will essentially get a normal X-ray without much findings. So the set of patients that fit into this syndrome are patients with medical disorders, primarily patients with bronchial asthma, chronic obstructive pulmonary disease, and even the recent COVID patients. So patients with medical disorders present with severe symptoms, but their imaging will be almost normal, like you see in this picture over here. Contrast with that, patients may come to your clinic with absolutely no or minimal symptoms, or just some mild symptoms like cough, occasional cough, one episode of hemoptysis, and when you do imaging on these patients, you can find a gross anomaly like seen in this X-ray. You can see there's a you can see here there's a mass in the lung, probably abetting on the pericardium. Probably this is an inoperable cancer of the lung. So the second type of patients that we get in our clinics are patients with minimal or no symptoms, but with possibility of an advanced malignancy. So these are the two ways in which thoracic patients can present. So in general, these are all the symptoms of a surgical lung: cough, hemoptysis, chest pain, and engorged neck veins. This engorged neck vein is because these thoracic masses can compress on the superior vena cava and produce engorgement of the neck veins. Now let us have a brief look at the surgical anatomy of the thorax. So all of you would have learned anatomy of the thorax during anatomy days. So let us just review those anatomical points that are important for a surgeon. So as you know, the thoracic cage is heavily reinforced with very bulky muscles like the pectoralis major anteriorly, and the latissimus dorsi, serratus anterior, and trapezius posteriorly. Once you get past this muscle layers, we have this sturdy skeletal cage. You can see in the center there is the spine, on either side the ribs branch out, and then there are true ribs, then there are floating ribs, and there is also the scapula. So this sturdy structures protect the vital organs that is inside the thorax. As you know that the thoracic cage contains the organs of oxygenation like the heart and the lungs. They are vital organs and they need to be protected, and that is why the human body is designed with this protection around these organs. So anteriorly again, like I said, there is the true ribs, then there are the floating ribs, and in the center there is the shield like bone known as the sternum. So you all know all these things. So what you have to remember is that the thoracic cavity is protected very well by a bony cage and a set of very bulky muscles, because they are protecting organs of oxygenation. So surgical point here is, since they are very well protected and hidden inside, it is not very easy to get inside the thorax to operate on this organ. Compare that with an abdomen where there is only a set of muscles. We can make an incision over the linea alba and you are right into the abdomen. While if you want to operate on the lungs or on the esophagus or on the aorta, you have to get past all these obstacles to get inside the thorax. We will see that in the subsequent slides. So, the inside of the thorax is divided into the centrally there is a mediastinum, there is a superior mediastinum, middle mediastinum and the posterior mediastinum, and on either side of the mediastinum there is the right and the left pleural cavities containing the right lung and the left lung. So, the important point to note is that the anatomy of the right side of the thorax is totally different from the anatomy of the left side. So, if you open the thorax on the right side, you will encounter the azygous vein that you are seeing over here that loops around the hilum of the lung. You will see the upper part of the esophagus. So, these are the main structures that you see on the when you open the right side of the thorax, apart from the right lung of course. While on the left side, when you open, you do not see the esophagus at all. So, what you see instead is the arch of the aorta and the descending thoracic aorta, along with a bit of the esophagus near the diaphragm. So, the surgical point here is that if you want to operate on the esophagus, we will do a right sided thoracotomy, and if you want to operate on the lower part of the esophagus, we will open the chest on the left side. We will do a left thoracotomy, and if you want to operate on the aorta, obviously we will have to do a left thoracotomy. So, these are all common MCQs for you. So, what you have to remember is that the anatomy of the right side of the thorax is different from the anatomy of the left side of the thorax, and depending on which organ that you are interested in operating on, we need to do thoracotomy on that side. So, that is the importance of surgical anatomy of the thorax. So, once we are done with surgical anatomy, let us have a look at the various investigations that are available with us to investigate these thoracic patients. The oldest and the commonest investigation we use for diagnosing thoracic disorders is the chest X-ray. So, even though it is an old investigation, it is a very effective investigation for diagnosing thoracic conditions, and it is indispensable, and it is still the first investigation we use for diagnosing thoracic disorders. So, this is an X-ray of the cervical rib. You can see it over here. This is an X-ray of a patient who is having a pneumothorax. You can see that there are no lung markings at all over here, and this is the margin of the collapsed lung. So, an X-ray is still good enough to diagnose this condition. This is an example of a patient having a complete whiteout of the left hemithorax with a meniscus sign. So, this is a patient who is having a pleural effusion. So, this is like the patient we have seen in the X-ray on the first slide, patient with a malignancy abetting onto the pericardium, probably making it inoperable. All this diagnosis we can make just with a simple chest X-ray. So, this is a patient with pericardial effusion. You can see that there is mediastinal widening and the cardiac shadow is very much enlarged. And X-rays are also an excellent method to evaluate patients who have undergone thoracic surgery post-operatively. You can see that this patient has got a small effusion, probably a collection of blood over there. So, these are the stainless steel sutures that are put over the sternum. Over here you can see the marking of the endotracheal tube, it is in the right position. So, X-rays are still very useful in diagnosing various conditions inside the thorax. But the investigation of choice for diagnosing thoracic disorders is a CT scan. A contrast enhanced CT scan of the thorax is the investigation of choice, and it is the most common investigation that we use to diagnose patients with surgical disorders inside the thorax. So, we will have a look at that. So, this is a CT picture. You can see this is the aorta that is running down the left side. Now we are back up. So here you can see the trachea that is there. This is the arch of the aorta, and the small shadow over there is the esophagus. Again, that's on the right side. So CT scan is interpreted in such a way that the patient is in supine position and we are viewing the patient from the foot end. So what you are seeing on this side is the left side of the patient. Obviously there is the spleen, and this is the right side of the patient having the liver. So you can see clearly here the right and the left bronchus joining to form the trachea. So what you have to remember is that a CT scan is the investigation of choice for imaging patients inside the thorax. As we have discussed in the first slide, many of these patients with advanced malignancies will present to you with very minimal symptoms. So you should have a low threshold for investigating these patients. A patient comes to you with cough for a week's duration, you try treating him with medications, he comes back next week, you should order a CT scan to see if there are any mass lesions inside the thorax. You should have low threshold for investigating these patients. Otherwise, we will only catch these patients in advanced stages. So that's not good. So that CT scan and X-ray will give you an idea about the anatomical nature of the disease inside the thorax. You can see that swelling or cyst or whatever, but that's not enough for a surgeon. So we also need to know about the functional capacity of the lung. We need to know if the lung is working, because we might have, there may be a cancer on the right side of the lung, we might have to remove the entire lung. We should know whether the opposite lung can sustain the patient. The patient is having diseased lung on both sides, we remove a cancer on right side, and if he is going to die due to hypoxia, then that's no good. To know the functional status of the lung, we do certain other set of investigations. One of that is a spirometry, which will be covered for you by the chest physicians. Then there is the arterial blood gas and DLCO2. So these are investigations that will give you about the functional capacity of the lungs. So we have chest X-ray and CT scan to assess the anatomy of the lesion, and we have spirometry, ABG and DLCO to know the function of the lung. So those are the two sets of investigations. So now next we move on to the access. So access means what is the incision we use to get inside the thorax. For a long time there was a problem facing surgeons, and they could not operate on the lung, because as you know that inside the thoracic cavity there is negative pressure, and once we make an incision and open the thoracic cavity to the external atmosphere, the air will rush into the negative pressure, the thoracic cavity, and that will cause collapse of the lung. And once the lung collapses, obviously the patient is going to pass away. So this is the problem that surgeons were facing for a very long time. So to overcome this negative pressure problem, initially what the surgeons did was they put the patient inside a negative pressure chamber and tried to do surgery within that chamber. But obviously it is very cumbersome to operate inside a box, and not many surgeries were successful, and complex surgeries were definitely not possible. So all that changed when the endotracheal tube was invented. So now we could counter the negative pressure in the thoracic cavity by employing positive pressure through the endotracheal tube, and surgeries on the thorax took off after the invention of the endotracheal tube, essentially in the early part of 20th century. So the tube that is used for doing thoracic surgery is not a simple endotracheal tube. A normal endotracheal tube, if you have gone to the OT and seen, will contain only one tube and one balloon. But the tubes that are used in thoracic surgeries have two tubes and two balloons. So where do these balloons go? Let's take a look. So the one balloon will stay, one tube will end in the at the level of the trachea, and another tube and the balloon will go into one of the bronchus, either into the right bronchus or the left bronchus. That way, suppose we are operating on the right side of the lung, we can keep ventilating the left side of the lung and collapse the right side of the lung. So that's the advantage of this double lumen endotracheal tube. So it has got a tracheal tube and it has got a bronchial tube. It has got a tracheal balloon and it has got a bronchial balloon. So this tube is used for isolating the lung, which we are going to operate on. The access to the thorax differs from an access to another cavity, like say the abdomen. Here you can see this is a large concert hall. So abdomen is something similar to this. So irrespective of whichever door through which you enter this hall, you can always have access to any part of the hall. So if you make an upper midline incision and then you find that the problem is there in the lower part of the abdomen, you can simply extend the incision and go to the lower part of the abdomen. So that's the advantage of operating on the abdomen. While entering the thorax is different. It is like the thorax is compartmentalized into different rooms, like in your hostel. So if you have a job to do in room number 204, if you enter room number 206, you will not have access to the room 204. So that's the difference between accessing the organs in the abdomen and accessing organs in the thorax. So the commonest route through which we enter the thorax is what is known as a posterolateral thoracotomy. So this is again a common MCQ. So we will do a right posterolateral thoracotomy if you are interested in organs that are on the right side, like the upper part of the esophagus, and we will do a left posterolateral thoracotomy if you are interested in, say, operating on the descending thoracic aorta. This patient, you can see that he is having a double lumen endotracheal tube inserted into him. So as we have seen in that picture on the on surgical anatomy, so once the skin incision is made, they will have to go through the subcutaneous plane, cut the latissimus dorsi, cut the serratus anterior, then you will enter the rib cage. And like I said, if you are interested in operating on the upper part of the thorax, you will enter the thorax through the 6th intercostal space. If you are interested in an organ that is in the lower part of the thorax, you will enter through the 8th intercostal space. So that's the difference between access to a single cavity like abdomen versus a thoracic cavity, where you have to carefully plan your entry point depending on which part of the thorax you are interested in operating. So once the rib cage is entered, cut open, and then you enter the thoracic cavity, we place a self-retaining retractor like this, and we get a very good access to the structures inside the thorax. So the commonest incision that is used for access inside the thorax is the posterolateral thoracotomy. Apart from the posterolateral thoracotomy, other incisions that can be used to get access to the thorax uncommonly are the anterolateral thoracotomy, which is used for giving open cardiac massage. This is again a common MCQ. This incision also used to be used for a surgery that was very common a decade back, namely transventricular mitral commissurotomy, a surgery that was done for mitral stenosis way back, probably 20 years back. Another common incision that's used all the time is sternotomy, and sternotomy gives access to the mediastinum, mainly the middle mediastinum. So all cardiac surgeons, they use sternotomy to get access to the heart, the pericardium, and the structures within the pericardium. So you want to access the heart, we do a sternotomy. For open cardiac massage, we do anterolateral thoracotomy. For most other procedures, we use the posterolateral thoracotomy, which is the commonest incision that we use for getting access into the thorax. So now that we have seen the various methods of getting into the thorax, what are the various surgeries that are possible inside the thorax. So, we will just have a look at them briefly. So, when the entire lung on one side is removed, it is called pneumonectomy. When only one of the lobes is removed, it is called a lobectomy. And as you know that lung is comprised of many bronchopulmonary segments. So, we can also remove just one segment if that lesion is confined to that segment, and that surgery is known as segmentectomy. Probably the commonest surgery that is done is a lobectomy. Then when we remove the, in patients with empyema, we will see in the next class, when we remove the thickened pleura from the lung, that surgery is called a decortication. So, once we have had access to the thorax through one of the incisions, and we have done one of the surgeries that we have planned, either a pneumonectomy or a lobectomy, then next comes the closure of the wound. The important point here is that we will close the wound only after inserting a chest tube. This chest tube has got two purposes. One is that if there is any air that leaks from the remnant lung, or if there is any bleeding, that will drain through this tube and come out. If we do not drain the tube, the air or the blood, that will compress the remaining lung and it will make the patient hypoxic. The second purpose of the chest tube is that we have made an incision over here and then we are closing it with sutures. And however we close, it is very difficult to make the wound absolutely airtight. So, if any air should go into the thorax through the wound, that will again be drained out through the chest tube. So, that is the purpose of inserting a chest tube, and also chest tube is inserted in various other situations, the most common of which is when patients have pneumothorax or hemothorax secondary to trauma, which will be covered for you in the class on trauma. So, this insertion of chest tube is probably the most important part of this lecture, and then that is probably the most common thing that all of you will be doing, and it is a rather simple and a life saving procedure that all of you should learn. So, insertion of a chest tube is an important procedure that all of you should know. There is a very good video by New England Journal of Medicine. I will attach a link to that video at the end of this lecture. And in the next lecture, we will learn about the specific thoracic disorders, some of them. And that will finish the lecture series for this semester. Thank you.